Welcome, everyone, to this episode of a special 5-part series of the Sunflower Palliative Care podcast. This is a collaboration between the Sunflower Children's Network and Canada's Pediatric Palliative Care Alliance. The series explores issues for equity-deserving groups in palliative care, including vulnerably housed and homeless communities, Indigenous communities, disabled communities, diverse sociolinguistic communities, and Two-Spirit LGBTQ+ communities. I am one of your hosts, Rachel Neufeld, nurse practitioner with Connect Place Children's Hospice in Vancouver, Canada. Today I'm speaking with Ben Carrol, a settler who was raised on Treaty 7 region of Calgary home to Blackfoot Confederacy, Tsuut'ina Stoney Nakoda, and Districts 5 and 6 of the Métis Nation of Alberta, and now lives on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation in Ottawa. He is a PhD student at Queen's University in the School of Nursing, investigating how trans and gender diverse nurses engage with concepts of binary gender when they encounter it in their nursing education practice. He also works as a research assistant for the Chaplain Health Palliative Care Program on improving palliative approaches to care for urban Inuit, which is a collaborative project with Inuit people living in Ottawa. His interest in equity, diversity, inclusion, indigeneity, and accessibility is grounded in clinical nursing practice, in pediatric post-op surgical care, and in leading by bringing cultural humility into the nurse-patient relationship. Hi, Ben. Thank you so much for joining us today.
Hi. Thanks for having me. I'm happy to be here.
I understand you have quite a wide variety of experience within our healthcare system. And the listeners have heard your bio, but I'm hoping you can share a little bit in your own words about your experience, your Venn diagram of nursing experience, and kind of how that stirred an interest in participating in this conversation, what brought you here today, and some of your background.
Yeah, sure. My pleasure. Yeah, before I became a nurse, I used to work in Western Canada as an archaeologist and had a background in anthropology. So I've always been really curious about, where people came from and how we behave and why we do the things we do with the things we do and with the people that we do. And I find that I draw on that knowledge a lot in nursing. When I went back to nursing school, a lot of the social science aspect of nursing and the theory around nursing and supporting people in healthcare really overlapped a lot with some of those ideas from anthropology and sociology. And at the time I went through nursing school, like the buzzwords were patient-centered care and evidence-based practice, and they kind of seemed at odds with each other a little bit, like because patient-centered care was all about figuring out what the individual needs and that kind of thing. And this evidence-based practice was all about like, let's generalize everything and find out what's under the normal curve and like maximize treatment and for the most number of people possible. But I always wondered, well, what about the people in the tails? Like, is that where we're doing the patient-centered care then? Is that meant to be globalized as well? And kind of aligned myself with the people in the tails, like of a normal curve, if you think of that normal curve. So I went into pediatric practice after nursing school and I worked in a surgical unit. So on the surgical unit, I learned a lot about patients and children asserting their needs and how they're going to do it, and whether it's, reverting a little bit back in their what's expected for age because they know how to get it. They were certain of how they were able to get things a little while ago. Let's go back to that means, and supporting parents through that and kind of having those conversations with parents about like, you're the expert of your child.
Yeah.
And your child is the expert in their own experience that they're having right now. And I'm the expert in how children move through the healthcare system. And so between the three of us, we've got to fill that gap in the middle of what I envisioned as a Venn diagram. And I use that analogy for parents sometimes by drawing it up on the whiteboard that wasn't having all the spaces filled in with all the information that the hospital wanted you to put there. We'd use it for drawing instead. And so that I'd put this Venn diagram of like the patient, the parents, and the healthcare providers. And there's this gap and of all of us where we don't know. And we have to figure all that out together. Like the three of us can't fill that gap on our own. We have to figure that stuff out together. And so I kind of think of my own practice in that way, because understanding that autonomy of kids and where we can get consent when working with kids, like when is it there? When are they mature enough to understand that? And when do we need to rely on their caregivers and their parents and
Hmm.
those kind of understandings. I really moved that forward when I started doing research in my master's around working with equity deserving groups and marginalized populations. So back to those people under the tails. So
Right.
I often put kids under those tails because parents kind of dominate in the healthcare environment when
Hmm.
youth and children are involved, and youth all the way up into their 20s, I'd include,
Totally.
as being a bit dominated by caregiving groups and particular parents. But my interest was personalized, queer and trans work. So that whole alphabet soup of two spirit, gay, lesbian, bi, trans, transgender, queer, intersex, and asexual. But my focus was mostly around trans and non binary and gender diverse. A lot of that consideration around how do we know what we don't know and how do we work with different people. And I just experienced a bunch of that in the healthcare system by working with other families who maybe had gay or lesbian parents, the kids, or whose kids were out, but understanding that they'd have a completely different trajectory to me. At that time I was kind of moving through the world as a lesbian woman, and so because I was a significant amount of age older than the children that I was taking care of, 20,
Hmm.
25 years, that they'd had a completely different perspective on that world by either having parents who were like my family or by moving through the world as a queer young person. And then when I came out as trans later, I was no longer working in the pediatric world, but I'd worked with trans and intersex kids in the hospital. And so thinking again about how their experiences were just fundamentally different than mine had been. And then lastly, I work these days as a research assistant on a project that's with urban Inuit here in Ottawa. And the project's being run by the Champlain Hospice and Palliative Care Program. That's looking at improving palliative approaches to care for urban Inuit here in Ottawa. And so that kind of brings it full circle because my archaeology world, I'd been up to the Arctic a couple of times and was really interested
Right.
in the North. So I'm really happy to be working with Inuit folks again. There's lots of Inuit people here in Ottawa. And then just thinking about that person centered care in terms of trauma informed care and the colonial and imperialist
Hmm.
history of the Arctic and Canada's sovereignty over the Arctic, but that means Canada's subjugation of Inuit people as well. All
Yeah.
of these things kind of come together in that research and in that work. So yeah, it's not a very short answer, but kind of my personal Venn diagram. So those overlapping circles of relationships are that pediatric experience, that equity deserving populations experience, and then this palliative care, palliative approaches to care that leave this sort of, you got to remember that there's a gap between those circles. There's not fully overlapping these
And
days.
I'm really excited to actually have some of this conversation because you have such a wide variety of experience that my brain immediately ties into the work that I do in pediatric palliative care specifically. The work that you're doing can inform how I do my work. And so really excited about this, and even just the first set of comments that you made about your pediatric experience, recognizing that difference between a parent or a caregiver being the expert in the child, and where the child's voice is and an expert in themselves, and then where the medical voice is, because that comes up so much in pediatric palliative care when caregivers, parents, loved ones are trying to make the most difficult decisions for their child. And the struggle that I see as well of the attempt in the medical world to go away from a patriarchal style of I am the doctor, I will tell you what to do. And we've swung so far over to feeling like we're laying everything at a parent's feet or a caregiver to make these decisions when your Venn diagram clearly identifies, in my mind, exactly what we're trying to do when we are talking about shared decision making is that a parent is an expert in the child has their own voice of what they're experiencing, and the medical team has a voice in making medical recommendations that are maybe evidence based or maybe they're experience based, because a lot of palliative care is more anecdotal versus
Right, right.
RCT evidence based. But I see that Venn diagram that you've experienced to be exactly the kind of struggle that we see regularly in children's palliative care as we try to find that Where is
Hmm.
the overlap and how do we meet each other in the middle somewhere to do that shared decision making? Because there
Hmm.
is patient centered and there is evidence, but it's also not one or the other. It's
Yeah.
shared. How do we help the other people see the other side of that?
Yeah. And the challenge, in particular for the parents, it's such a huge challenge for the parents because the decisions that they're having to make, they're kind of holding that decision in trust for a child when they're older, basically. They're making that decision for the child right now, but the decisions they might be making are going to have ramifications on that child for their whole life, recognizing, palliative care, including like chronic long-term illness and frailty and not necessarily end of life. So those decisions are going to have consequences for years to come. And that's where you could see a lot of that in surgical experience in the hospital with kids. A lot of things that I consider an intersex condition, the medical science may or may not, or depending how they define things. So something like a hypospadias, for example, which
Mhm.
is where the urethra isn't on a penis, isn't necessarily at the tip of the penis, it's somewhere along the shaft or even at the base of the penis based on in utero development. Some folks don't necessarily consider that an intersex condition, but I think when you're thinking about why you need to have a correction for that, or what are the reasons or what are the rationales that you're doing a surgery on a very small person,
Mm.
where sometimes the location and placement of that wasn't a risk. The risk is they won't be able to stand up to pee. Well, that doesn't seem like a huge risk that warrants this surgical condition. Maybe this can wait and see, but other people have very, very strong views on why that's not the case. It's been a long time since I've researched any of that, but I still feel pretty strongly that for some of those things, maybe the parent's decision is to hold that in trust for their child to make that decision for themselves when they're older.
Mhm.
I think that it's a very personalized decision that people are making for a
Mhm.
kid that's going to have ramifications for years to come. Perhaps that isn't the
Yep.
choice that that child would have made because they're not clones of their parents. They might not be making the same decision. They're going to have a completely different view on the world. In the future might be framed by the fact that they did or didn't have that surgery at that age
Mhm.
because you've automatically changed the trajectory of that kid's life by making that decision in that moment.
Absolutely, and a child's values may differ from their
Mm,
parents despite living in the same
yeah,
environment, growing up in the same household culture. Their
yeah,
values may be different, and
yeah.
we absolutely see this on a daily basis in pediatric palliative care too, where a child is trying to make decisions around taking treatment or not, and parents struggle with
Right.
we do treatment or not, and what interventions are helpful,
Mhm.
what would not be beneficial. And so we talk a lot about trade-offs in
Yes.
decision making in peds palliative care of let's discuss the trade-offs that have to be aligning with your values. And so identifying that sometimes it becomes just more distressing when the values of the child or young adult or youth may not be the same as the values of parents. So not only do we need to try and come with curiosity to a family's values, but part of this conversation is when those values of a child and parent maybe don't align. And how do we help families walk through that while we're also medical providers that can provide that third piece of the Venn diagram of information and trying to make those decisions. I'm seeing this as one of many barriers, and specifically today's conversation focusing more on the two-spirit LGBTQ plus communities, particularly in children, youth, what we say AYA, adolescent, young adult populations.
Mhm.
So decision making being one of the potential barriers which can impact how they receive treatment, when they receive treatment, and can impair the treatment of particular conditions. And so again in pediatric palliative care that can have significant impact in trajectory. But I'm curious about your experience in doing the work and the research around trans and queer experiences in healthcare. Are there other barriers that can impact their health in various ways that we need to talk about?
Yeah, I mean, I think definitely understanding family and kids' values and relationships between each other and those values are essential. And I think a lot of that can start even before somebody gets to more specialized care, like with a palliative provider, like with a primary health care provider, for example, or a pediatrician, or in a hospital, hospitalists and various teams that somebody might interact with before they even get to palliative care. One of the number one ways in both adult and pediatric land research is avoiding healthcare altogether, whether that's due to anxiety or fears of what might happen or how they'll be perceived or how they'll be understood, or whether it's due to previous experiences that have already validated for them the fears and anxieties they might have about that, or whether it's even they've had an experience of floating some of the ideas around themselves and who they are to family or caregivers and been received in an unsupportive way. And so, well, if they can't understand when I'm talking hypothetically about sexuality or gender or difference in people, how are they going to understand that I'm feeling different because I'm experiencing X, Y, and Z about my health, or that I'm worried that something is happening, or this hurts, or this I can't manage something, whatever their symptoms are leading up to that. So whether it's a conscious avoidance because of that, or less conscious, but more this family member or caregiver is my gatekeeper to this healthcare experience. I need them to make the appointment with the right person. And even when I get there, I can't trust this person who is my gatekeeper to this and my support person to necessarily support me in the way that I want either. Or can I talk to these people when I get there, and like, am I
Can I
putting
be
this person that
honest?
I love and is supporting, am I putting
Mhm.
them in the crosshairs to then have to make a decision and figure this out as well? So yeah, can I be honest about myself? And so one of the papers I was looking at recently is from 2021, and it's all about healthcare interactions of trans folks, and they're all adults, but one person in the conversation is a qualitative paper, so there's only a dozen people or so, but one of the folks had liver cancer when they were a child,
Mm.
and then had survivor care with their oncologists and everyone through into their adulthood. But they talk about how they always felt like they were putting on a character whenever they went to see their
Mm.
oncologists or their follow-up folks, and that, that the stereotypes were just so entrenched in the whole experience of being, in this person's case, a young woman, even though they were a trans man, but they weren't out to people. They also had high regard for their healthcare team, and so that was just another group of people that they felt whose opinions was really important that they had to come out to, and they didn't know how they were going to be accepted and if those people were going to be accepting and what that meant for them in the long term and how they felt about that. So it was just another layer of not being out to very important people in their lives as well. So they put
Mhm.
on this character and were hyper aware of gendered things to the opposite extent in those environments. They didn't go into exactly the depth of it, but they wanted to be regarded as those people saw them, like to
Right.
reinforce those stereotypes by
Yep.
presenting those stereotypes to those people.
And so there's like two major themes that are both going to have serious impact on this population of mistrust, a distrust, a broken trust in the system, in
Mhm.
healthcare, but also in people. So potentially family or loved ones, potentially the healthcare providers that are providing recommendations and trying to find this shared decision making. But if there's a broken trust or a distrust, then how do you actually meet somewhere
Mhm.
in listening the way that each party needs to listen in order to kind of find that shared ground to do shared decision making? So there's a trust issue here, and then there's also this power dynamic that we talked about a little bit in our previous conversation too. And there's a power imbalance between, like you identified, a child has to depend on their loved one to make the appointments, to take them to appointments, to maybe not take them somewhere if they don't want to go.
Yeah.
And then there's also that power dynamic again, like it keeps coming back to this Venn diagram of the power between the healthcare provider then and the child. Is
Yeah.
there probably also power dynamics between the healthcare provider and the child's parent or caregiver, loved one, etc. So both themes, I think, interact and intertwine in a way that can't really be teased out specifically, but I'm curious how we might actually address some of those things. Are there ways that we can learn, and what can we potentially do about some of these barriers or some of these inequities around the trust piece and around some of that power differential?
I think there definitely are. I mean, some of the other barriers and things that get mentioned in the research all the time, beyond like the stereotypes and assumptions, but also like negating a person's identity, just washing over it, or overtly kind of disrespecting or dehumanizing. That paper that I mentioned earlier, the title is like, I'm not from another planet. So that idea of like, this is so foreign to people when they encounter it in healthcare environments, that they just have this experience of like, that's just too weird. I can't handle it. I got to
Right.
get my stuff done today. Like, or we won't treat you. People being outright denied care, possibly more in adult land than child land, but regard, it's a thing. And then invisibility in the system, which I think would be a more of a thing in pediatrics as well, just because I think
Yeah.
the child sometimes does get invisibilized. There's an idea that because kids are developing, that they're not a fully realized human
Yeah.
already, but really and truly, they are a fully realized human. All of us are changing and developing, and it's not like we hit 18 or 21 or 24 or 29 whenever they say our frontal cortex is like locked in stone. There's a whole neuroplasticity and the way our bodies are going to keep changing, and our
Absolutely.
relationship with our bodies and our understandings of ourselves. You're grappling with gender every day
Yeah.
of your life when you decide how you're going to greet the world, how you're going to fit into stereotypes, how you're going to push back against stereotypes, how you're going to present yourself to the world so that people are making assumptions or not on how you move through the world, and how you address people, how you get addressed by people, how you make them aware of who are your people in the world and how you function in it. Like, all of those things have a gender dynamic to it, as well as a whole host of other things that we all make what essentially are stereotypes, little shortcuts to kind of make those social interactions fluid. And so there's no denying those. So we have to make a conscious effort then, I think, to make things more affirming experiences or more validating experiences, that is that person-centered way of doing things. So we might be working from an evidence-based system dynamic of, here's the thing that's the best for the 80% of the people, or outside the two, standard deviations from the norms. Well, maybe this person might be in beyond those two standard deviations from the norms. So I need to be aware that that's the case. How do I come to understand those things? Like, you need to ask questions. You need to have, that means bringing, for all patients, like an ethical, compassionate, and genuine curiosity to your work, or to their lives, basically. Maybe not to your work, but to their lives. By that, I mean, ethically, do I need to know these questions? Like, it's all well and great to be excited to meet somebody who's just emigrated here from someplace really interesting to you, or, this is the first trans person you've ever met. Maybe I can ask them all sorts of questions.
Right.
You need to ask the questions you need to know, and you should be able to justify why you need to ask that question. And if you don't, then you need to go do your own homework. Maybe ask trans people, adults, or older youth for one good website recommendation. But otherwise, go look out there. There's work that myself and others have done to make that information more prominent, more available through a bunch of our different healthcare systems and professional bodies, that you don't need to pepper trans folks anymore, or
Do
non-binary or
do
gender
your
diverse
own
people.
research as a
Yeah,
clinician
evidence-based
instead of
practitioner.
expecting yeah,
Yeah,
instead of having your patient educate you
yeah.
on the things that you're ignorant to or not
Hmm.
familiar with. Yeah.
Because they're going to have to educate you potentially from their own personal experience, and some of that
Yeah.
stuff isn't your business yet, unless it needs to be your business. In
Mhm.
which case, you need to have a way to ask them about it that is affirming of who they are as a person. And
Yeah.
so, in terms of gender stuff, that might be asking, like, for all my patients, part of my job as a primary care provider, or a pediatrician, or a geriatrician, or in palliative care, is to still make sure that people are undergoing the necessary cancer screenings that everybody has to undergo. And so, in order to do that, I need to understand for you what organs might be present that need cancer screening. And so I understand that different trans people, or non-binary, gender non-conforming people, may or may not have undergone medical and surgical care that can vary. You don't have to do any of it. Maybe you've undergone nothing, or maybe you've undergone all sorts of things. And so we need to have a conversation about cancer screening.
Yeah.
and then do an organ inventory, which is simply listing,
Right.
have you ever had any surgeries that have removed stuff, even your tonsils, even your appendix? Like, start with generic things that lots of people have had removed, and then work your way along for what makes sense for that person. It's going to tell you lots of things. Have they had an anesthetic before? Did they have an adverse reaction when they got their wisdom teeth out to narcotics? Did they have in their family an adverse reaction to anesthesia that is really important to flag? Is there a chance right now they could be pregnant? Could work into that conversation in a way that is affirming of who they are as a person and upholds your responsibility as a provider to still make sure that everybody's getting cancer screenings that they need. And how can we make that supportive? And if you yourself don't do pap smear or the prostate check that the person requires, who you're going to send them to, is that a safe person for them to go to as a transgender diverse person? A lot of that requires a lot of cultural humility from providers in terms of being aware of what they know and what they don't know. When they don't know it, do they know where to go get it? And if they don't know where to go get it, do they know who to ask?
I also link your work with Inuit and some of our conversations around Indigenous populations too, in terms of I might go and read some papers and try and educate myself on improving my approach to care of a trans person, perhaps, and recognizing that that person's experience, like you've identified, is unique to them as well. So there's a certain amount of information I can gather from the work you've done, some of the research that's out there, some of the approach to care. And I still have to come with that humility and curiosity to explore appropriately and ethically. I appreciate that bit too of what do I need to know from this person specifically about their lived experience. So even top of the conversation, each child has their own lived experience with their own condition. And so I might think that I know this much about this particular topic, and I still have to come with that humility and curiosity to explore what that one person's experience is too, because just because I've read some papers does not mean I understand trans care.
Right.
And so also linking your work with the Inuit is some of the things that I've learned in some of the reconciliation work that we do in healthcare, and is that similar to the conversation of each child, like a child's values might differ from their parents even though they've lived in the same household. Each person within a community may also function differently within their own lived experience. So just because I come from a particular cultural background or my family is a part of a certain community or group does not mean that my experience or all of my values align with that group.
Right.
So that humility is so key to not coming with assumptions that I've read about this population and then I know. So balancing the do my own research and come with humility and curiosity, but I appreciate the with ethical questions. What do I need to know in order to provide really good care?
Yeah, and I think, Inuit example is a really good example potentially to think about that you can have generations within families that have really fundamentally different ideas about all manner of things. But in this particular instance, there's a great film. I wish I could remember the title off the top of my head, but it's available, I think, through the National Film Board of Canada. And it's set in the 1950s. The Inuit folks are in the film are adults, but there's one person who's bringing this white person and called an Indian agent from back in the day. So the person for the government who kind of regulated things for Inuit people in terms of resettlement into communities in the north or movement of settlements in the north. So in this one scene, the one person who was behind in the community brings this government agent out to the hunting group that's out on the ice. And the two people who appear to be men greet each other. And the one person says, "Hello, grandmother," to this other person that's taller than him, younger than him, bigger than him, all of these things. So really highlights that for a lot of Inuit group who were living in traditional ways, they could name somebody after an important ancestor, and that child shared that embodiment with that ancestor, and so might take on some of the roles of that person in the community, potentially take on their name, would take on their gender identity, maybe their manner of dress, depending upon where that kind of fell within colonialism side of thing, when the government and the church and the RCMP were dominating how communities functioned. hence why this person who's ostensibly to our outside point of view, this young, healthy man is behind and not out with the hunting group. He stayed back because he's also grandmother and he's staying back and working with families. This person had a role to fulfill back in the community. It's just a really good example of how you can have one generation who would be elderly now, and then the next generation who would have had this serious and severe colonialist influence from the RCMP, the church, the government on their life, and may now be younger elderly or older middle-aged people who are really entrenched now in some of those things, and then a younger group of people whose ideas about gender and sexuality are influenced by Southern Canada, possibly,
Right.
or maybe they're more interested in what their elders are talking about or how they lived their life, what we know about gender from conversations with elders in Inuit community who lived in that way. And so you can have these really different cultural ideas moving across different generations of a family. And it's not unique to Inuit. I mean, we can have that across different generations. Trans people and queer people are an example if their parents are cisgender, heterosexual.
Yeah.
So I think a lot of those things we need to consider that in our practice. But one of the examples I often use with nursing students is that you could take care of one of a pair of twins one day, and then you take care of the second of that set of twins like the following week. You can't make that assumption that the things are going to be the same even for that other person, even though they're genetically potentially identical. Lots of they've grown up in the same household, possibly they've experienced a lot of the same things, but they've experienced them from two different points of view. And now this person that you're seeing in the second week has had the experience of having a sibling that experienced the same things and parents who had to go through the stress of whatever it was just the week prior, for example.
Right.
That kid is going to have a completely different perspective on that just from having witnessed or been part of that group, or maybe not being sent to some other caregiver while all of that was happening. Now they've had this experience of being separated from that family unit while they went through that. And possibly how are they feeling about being brought back into it in this way? So it's one of those things where maybe the assumptions you're making, not only are they not okay, but they're maybe making things a little more dangerous for you because they seem like they should be so easy or straightforward. This person's a lot like the person I took care of before who was exactly like X, Y, or Z for whatever reason.
Yeah. And I have a couple of examples that are going through my head as you're talking to of families that have had this kind of varied experience. A family that has lived in Canada now, but family have come from another ancestral area, or they're coming from another country. And so their perspective on the care being provided to the child is different. It can create distress and it can create tension, even though what we all assume is that family coming is going to be supportive for you. And it's not always the case. It can be both. Like the family is our loved ones and can be supportive and can create tension because the ideas and the perspectives on how that child's being cared for differ. But then I also think about your work with nursing students. So I'm curious if we can talk just a little bit about how that piece could be helpful and how you're embedding some of this work into curriculum. And as healthcare providers, how are we learning to provide our care a little differently? And what are some of the things that can benefit from trying to embed some of this work that you do into curriculum? Nursing is what you're focused on, and then I always think about medical curriculum as well. Can you tell me a little bit about that work?
Yeah. So some of these ideas I've taken up in my own PhD work. So where I plan to talk to other trans and gender diverse nursing educators about what they do when they just encounter stuff in their day-to-day work that presents a gender stereotype, or that idea of gender just being a binary, or that people are locked into these ideas of gender from birth and that's it, and that's just the way it is kind of thing. What do they do to push back against that? And so even I think some of the ways that I'm thinking about that in terms of it being a curriculum, even though it's kind of the hidden curriculum, is that I'm including nursing students as educators, because I think trans and gender nonconforming nursing students have to do a lot of that education work for their peers and for their professors and for their patients that they're working with in their practice potentially. But I think too is also recognizing that people don't necessarily take up pushing back on some of those things all of the time. Like you can't push back against that every single time and still expect to be able to function with the rest of your work. So when is it that what is it about probably the education environment. A lot of our hospitals are education environments. So what is it about the environments that we're educating in that makes some of those spaces open for these conversations? And when are some of the times that we have to close those conversations? And when is it that these conversations are able to be open? And so I think reflecting on when we're able to push back against all sorts of things that we encounter as healthcare providers, sometimes you push back and sometimes you drop it. And why I think it's an important self-reflection for ourselves to be able to understand, why is it that we push back sometimes, and why is it that we go with the flow? I think too, there's a lot of ways that we can bring individuals' lived experiences into understanding for healthcare providers. But I think it's really important to think about how we do that ethically. A lot of the programs have a lot of simulation involved in them now, which is really important because of a lot of factors. That simulation is a good learning methodology, but you still need to get some of that directly from the people whose experience that's lived. So you can't necessarily engage actors to present some topics well or in a way that is accurate or good. There's a lot of those different cultural influences among different groups and understandings of gender that don't match what people in the Northern Hemisphere and the Western hemispheres understand gender to be, or understand how it works. And so there's a lot more research and understanding that needs to be brought into that for how global Indigenous people think about gender and how that worked through colonialism and imperialism in our collective histories. And how to undo that in an ethical, compassionate, and genuine way, rather than at face value and kind of a one-off or just a side note or a tick box. It's none of those. Right. A lot of these things around identity and who people are, whether it's race or gender, ability or social class or status or, ethnicities and all sorts of things, you can't tick box those conversations. And so that genuine curiosity is about, sometimes these conversations are really difficult to have. They're really difficult to have with people who are different than you. And you need to, in order to trust that this person wants to really engage with you, you have to trust that they're going to take what you're saying and try to understand it. And sometimes that means, for healthcare providers, cultural humility might be simply turning away from your computer, trusting that you'll be able to remember enough of this conversation that you don't have to document it in the moment, and turning around and either sitting alongside or facing this person, depending on what's more comfortable from them, and just turn away from your computer for a minute. Like, it could be as simple as, like, I'm listening to you. I understand that I asked you a question that might be really hard for you to answer. I'm going to rephrase it as a yes or no question, and I'm going to give you lots of time to think about it. And if you don't want to tell me, you can tell me that too. And do that. If you recognize those questions, pull it back, make it short, and then give the person lots of time. But questions around some of these topics, do go into, are you thinking about killing yourself? Are you thinking about hurting yourself? And questions like that need to be a yes or no question. You might be the first person that's picked up on this and the first person that this person's telling. And so that yes or no might be the most difficult yes or no they've ever spoken in their entire life. And they need time to decide if they really trust you. That also points to a lot of conversations in this area talk about cultural safety and ensuring cultural safety. I don't think we can, as healthcare providers. Only that person who's answering that question can determine if that moment is safe for them to answer that question. Yeah. Or if they're going to risk it being a little unsafe. And you can't guarantee that that's going to be safe the next time you see them either. That yes, they shared that with you last time. Maybe they're back the very next day because you're that concerned about them. They've lived a whole 24 hours in that time, and things might be different now. You haven't magically produced cultural safety in this therapeutic relationship, and you're going to be able to just run with it because you had a moment yesterday where a person had a breakthrough of some sort.
Exactly. And it's that idea of the humility, which is, in my opinion, the phrasing of cultural humility gives the sense of ongoing action, as opposed to cultural safety or cultural competence, which I've never loved the term, because it indicates an endpoint that you have accomplished. And I don't think we can. And so much of what you're talking about today pairs or aligns with a lot of the work in terms of the conversations we have to have in pediatric palliative care. And specifically, we do a lot of teaching on what's called the serious illness conversation. But some of the key themes of getting permission to have the conversation. This is what we want to talk about today. Is that okay with you still? Even though you might have pre-organized that day, you still have to receive permission to have the conversation, to be asking the kinds of questions with curiosity to learn about what your values are as a person or as a family, or whatever unit we're talking to, the curiosity to learn about your experience and what's most valuable to you, and the permission to also end the conversation. I've had many where I have said to family members, I usually say, and if at any point we need to stop this conversation, just say the word and we'll stop, because it's a really difficult conversation to have, and therefore is not one and done. So the other thing we
Right.
teach in providing some of these specific kinds of conversations is that we often have to come back to them. And a parent needs to be ready to have that conversation. A child needs to be ready to have that conversation. And some of our parent faculty have given us feedback too that not every time is a good time to sit down and have this difficult conversation. So today I might be not able to, or I might end the conversation. Tomorrow I might be in a different space and be ready and able to have more of the conversation. So again, coming back to conversations in a different space in a different time can mean a different outcome, and that we're giving the permission to do that, to end the conversation, and we're getting consent to have the conversation every time. So
Right.
coming with that curiosity. And the other piece of really essential communication, which teach a lot of in palliative care, is that active listening. So the last piece that I'm hearing in all of these themes of Indigenous care and queer community care and all these different equity deserving groups that are those outliers of the bell curve, is that we provide the kind of conversation that shows them that we're truly listening. So that active listening is the term, but we do have to teach ways to show up compassionately that show that you're really truly listening. And you may not fix whatever the experience is. You may not be, and in pediatric palliative care, we're often dealing with something we cannot fix. And so we're showing that we can come with you in your experience. I can only imagine what you're going through, but help me to imagine so that I can be compassionately with you. And
Right.
I hear that in a lot of the sort of topics that you're touching on today, is all kind of embedded in some of those conversations that we try and teach in palliative care and how we're approaching. And we have a different kind of conversation with a parent or caregiver versus with the child or youth. I see that all intertwining. So a lot of what you've talked about, I think, really does fit in a lot with the work that we do specifically in this specialty. You clearly bring a lot of broader experience in that. And some of the things that I've heard too, in terms of how we educate ourselves as healthcare providers, how we approach these conversations with humility, curiosity, and we need to show that we're really listening. We don't necessarily have to come up with solutions or problem solving or fixing, but we have to show that we're supporting them in what they are sharing so that they can maybe build that trust. Again, top of the conversation, that mistrust in
Yeah.
healthcare, in providers, and other people. If they feel heard and listened to, will that improve A, their experience, but B, building trust so that they can engage in the healthcare system in a different way.
As you were talking there, I was thinking, like, just in terms of engaging children, meeting them where they're at in those conversations, that I think a big piece for me that I've not really considered before around cultural humility, and that I don't know, is that being ready for people to surprise you.
Mhm.
And I think kids are always good at that.
Yep. They prove
Not
us
only
wrong all
literally,
the
yeah,
time.
yeah, popping out from behind doors or whatever, but
Yep.
also in terms of, surprisingly, young kids can have really big ideas
Mhm.
about life and death and their relationships and their understandings of families and
Mhm.
themselves, that I think for health providers that work with kids, like, we're privileged to get to witness and be with them when they have those profound moments, and recognize that, what seems like wild imaginary life or whatever that some little person is going through is also really tied in intimately to their actual experience and what
Yeah.
they're experiencing and how they're moving through things. And I think a lot of people, for whatever reason, give kids short shrift
Yeah.
on the depth of experience and the depth of understanding that they can have about things like pain and suffering, their own needs and how to meet them, life and death, who they are as a person, including gender and understanding of how they move through the world as a man or a woman or a gender diverse person.
And I agree, and
That's
that's something that we all hold the perspective of too, is that kids often know a lot more than we give them credit for. And if we don't share with them, they will make things up
yeah,
and their
they'll fill in
imaginations
those
can
gaps.
run wild. And so
Yeah.
having those honest but developmentally appropriate conversations with the kids is just so essential in how we're sharing with them their
Mhm.
healthcare experience.
Yeah.
Ben, I thank you so much for taking the time to talk with us on this podcast. I've thoroughly enjoyed the conversation. There's so many good things that we can learn and pull together into all these different Venn diagrams that are floating around in my head now of how things intersect. And I think that there's some really great themes that we can take away no matter what kind of work you're doing, no matter what population you're caring for, that it kind of holds true in how we really should just approach caring for humans in our work in healthcare. So thank you very much for taking the time. Anything else that we haven't touched on that you'd like to mention?
I provided you with some links. I hope if for
Yes,
folks who are interested,
thank you.
there's some other resources and links to different curriculum options and things that are available
Yes, thank you so much.
for
There will
further
be
explanation.
Yeah, there will be links in the show notes there for some of the work and access to some information about some of these topics. Please check them out. Thank you again, and I look forward to maybe some future conversations.
Yeah, my pleasure. That'd be great.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. This unique series on equity in children's palliative care is produced in collaboration with Canada's Pediatric Palliative Care Alliance with support from Health Canada. I just wanted to take a couple minutes now at the end of this episode, which is the 5th episode of a 5-part series, and talk a little bit about some of the themes that I have gained from some of these conversations and how I think it allows us to approach the care of anyone that we're looking after with similar themes and how we can potentially improve our approach and our communication with a wide variety of people. And some of those themes overarching all of the populations that we've talked about have included coming with curiosity and humility. And how do we ask questions so that we can learn about the person we're looking after, learn about their values and their most important goals within their own healthcare experience, or the parents of a child who's going through a healthcare experience. And how do we come with that curiosity that shows the person that we are truly listening, that we actually care about what they're saying, and how can it help build trust in each other, trust in the healthcare system, so that perhaps they can engage in the healthcare system sooner, more meaningfully, follow through on treatment, things that can become barriers. How do they perhaps improve their communication with their healthcare providers because of potentially improved trust? I think that these themes are fairly common in pediatric palliative care as a whole, and I just loved how these themes were able to be threaded throughout all of these conversations with people with lived experience, people working with particular communities and groups of people, and that if we approach our patients with this curiosity and humility, I think everyone benefits. So thanks again for taking the time to listen and be a part of this podcast. This, of course, is the Sunflower Podcast, which grew from a seed of an idea when we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, which focuses on children's palliative care. We hope to build a world where no child suffers from serious health-related issues. To learn more, please visit twoworldscancer.ca.